Funding for this program was provided by the Annenberg CPB Project.
Sometimes, as we go through life, we master our experiences. Sometimes we don't.
Some people have high blood pressure, other people have ulcers. I just happen to be one person, I don't know why, that has anxiety disorder. When a huge amount of stress or pressure is placed upon me, it comes out in anxiety.
I avoid being home alone. I avoid shopping alone. I avoid anything really alone. I don't do anything by myself.
Just watching a television show where there's there's a camera angle from the top of the building, and its heights, just sitting in my own living room, my hands would spring to sweat and my heart would pound and race, and I'd probably get up and walk out of the room. It just brought back so much of that terror, and it makes it real easy to want to stay away from a situation like that when that gets reinforced over and over.
Every day I'd go through 2 or 3, periods of anxiety, and that's the thing that scares you because you don't know when it's going to come on, and you don't know how long it's going to last, and you just don't know what it is. And you don't go to the hospital right away because you think, well, maybe it'll go away, maybe it's just something that I'm going through right now. But my breaking point was when I reacted physically to it and I just started crying.
Anxiety. There probably isn't a person around who hasn't felt it. Fear, apprehension, often the expectation of an unspecified danger.
Anxiety is a very normal, natural response that has counterparts in the animal kingdom as well. So animals have anxiety about things, and so do humans. So we use this every day to decide whether or not things are truly dangerous to us or whether or not they're not. And if they are dangerous to us, then our body continues the alarm until we know what to do about it, until we've had time to either run or stand and fight or outthink our foes or whatever.
Even though it's perfectly normal to feel some degree of anxiety in our daily lives, for many people, anxiety reaches extreme proportions, robbing them of the smallest pleasures.
If we understand that anxiety is a normal, natural response, then we can also understand that it can go awry, just as any of our other normal, natural body responses can go. So what helps us differentiate normal anxiety from abnormal anxiety or anxiety disorders is its intensity, whether or not the intensity of the anxiety that you feel really matches the circumstance, one. If the length of the anxiety is inappropriate to whatever is causing that anxiety. And 3 is whether or not we're able to adequately respond, to make a decision about what to do in that our body has alarmed us to some danger.
The anxiety disorders are the most common of the mental disorders, with the exception of substance abuse. Anxiety disorders affect 1 in every 6 Americans at some point in their lives. That's over 32 million people. In this program, we'll hear from patients who suffer from various types of anxiety disorders, and we'll explore 2 of the most common in depth: panic with agoraphobia and generalized anxiety disorder. We'll learn what it feels like to have these disorders. We'll learn about the biological, psychological, and environmental factors that may contribute to them, and we'll see what treatments seem to work. Panic disorder and agoraphobia are 2 separate anxiety disorders that often occur together. First, a look at panic disorder. Dennis Shulman is a psychoanalyst and professor at Fordham University, where he teaches abnormal psychology. He talks about a patient who has panic disorder.
Paula is a patient who came to me when she was 29 years old. She was referred by a physician, and she went to a physician because she was complaining of cardiac problems. She would be walking in the street or going in an elevator or at work or at home, and she would find all of a sudden that her heart was racing. She went to the physician who worked her up for cardiac problems and found that the appropriate diagnosis in her case was panic disorder. Paula would experience approximately 8 to 10 panic attacks each week for the last 5 or 6 weeks by the time she was referred to me. Now, these attacks would be very discrete episodes. They would have a beginning and they would have an end. From Paula's point of view, they felt like they were very, very long, hours.
In fact, Paula's panic attacks lasted for minutes, not hours. But as panic researcher Dr. Diane Chambliss tells us, those minutes can be terrifying.
Imagine that you're crossing the street and you look up and there's a big truck getting ready to flatten you. Okay, so think about what your body does at that time, about how your heart races, and maybe it feels like your legs are just going to give way underneath you, and your mouth goes dry and you tremble and so forth. I mean, these are all things that people feel when they have a panic attack. So it's a very high state of anxiety. And the only way it differs from just ordinary ongoing anxiety is that it happens so fast. So that it has a very rapid onset and it hits max really quickly. So that people often feel very out of control because they flipped into this high state of anxiety so quickly. And that's really the hallmark of what it's like to be in panic, is to feel out of control because you have this rapid surge of anxiety. It's somewhat unpredictable.
Another aspect of Paula's situation was that she was preoccupied with the next panic attack. It wasn't just that she was experiencing a panic attack, it was that she was anticipating the next one. Sometimes we talk about this as fear of fear as being a very important aspect of panic disorder.
Sometimes the fear of having panic attacks leads to a second but related disorder called agoraphobia. It means literally fear of the marketplace. But in practice it means avoiding activities or situations that may leave people feeling out of control and vulnerable to having panic attacks.
Driving? I just totally avoid it. I'm afraid of being out on the highway and having a panic attack, while I'm driving. What am I going to do? I'm afraid of wrecking or, stopping a car in the middle of the road, or not being able to get back home. Even walking, to walk. I could walk so far and then, as long as I could see where I'm coming from. And once it gets out of my sight, I'm panicking. It's like I turn around and come back.
In terms of who comes in for treatment, the great majority of the time, people who have panic disorder have developed phobic avoidance on top of that. Now, it may be relatively mild or it may be severe. So we go from people who just avoid a few things and not even all the time to people who are housebound or even room-bound or bed-bound, at its most extreme case.
But what if you were thinking about going alone? What would it feel like thinking about it, just even right now?
Terrifying.
Why is that?
Because of panic attacks.
And have you had those panic attacks? Mm-hmm. Tell me what that's like.
A panic attack?
Yeah.
It's just, I feel like I'm going to faint. My heart beats very fast. I get dizzy, I get all sweaty, my legs wobble, and I get really disoriented,
It sounds scary.
It is.
How often do you have them?
Whenever I'm alone.
What I had done was build a coping world around myself where I was unable to travel certain areas. I just avoided certain kinds of travel. It was affecting my career.
On a day-to-day basis, it's not really too much of a difficulty because his phobias are more isolated, and so it doesn't have a daily impact. But some of his greatest phobias are bridges and long-distance travel and things like that, so that we really can't plan trips together, especially trips that might include bridges or something like that. So we, we're limited by what kind of traveling we can do, or can't go to cultural events because it's scary for him to be up high on balconies and things like this. So if I want him to go with me, it creates, quite a conflict, because he doesn't want, he just can't do that.
There were serious setbacks for me. I had to fabricate stories and come up with all kinds of clever schemes to get out of doing things, and it affected career choices and got to be pretty critical.
The ever-present fear in agoraphobia is, will I have a panic attack? And if I do, can I handle it? Patrick describes his worst-case scenario for a panic attack.
Having an attack, people running around, gathering around, making a real big deal out of it. Having to call for medical help, just things like that. Making a real big thing out of it, calling all the attention toward me because of that.
For many people with agoraphobia, the only place where they feel safe is at home. Or if they have to go out, they must bring a companion along.
I think the not wanting to leave the house has to do with what one investigator has called safety signals. What that means is the person who is agoraphobic is frightened to death of the return of a panic. And the thing that determines their level of comfort is the degree to which they feel they're in a situation in which they're safe. That is, somebody will take care of them should they go out of control. So home is often a safe base because there is protection around. A safe person, for most people, it's extraordinarily important, more than a place. So that that person's presence becomes that safety signal. And when the further away they get from that, the more they feel blocked from getting back to that safe place of person, the more anxious they are. So home is not so much the issue as it is what will happen if I go out of control. How safe is this place when that happens?
Doctors Alan Goldstein and Linda Welsh run a 2-week intensive program in Pennsylvania to help people with agoraphobia and panic get over their fears. Condensed treatment programs like this one have been shown to be effective in dealing with patient attrition, setbacks, and loss of motivation, all problems common in long-term treatments. They provide daily opportunities to practice coping techniques to confront anxiety in a small and supportive atmosphere.
Pretty scary, trembling, sweaty.
Did you just now?
Yeah.
Scared you?
Yeah. Well,
but you pushed on.
I don't know that it really scared me, but I really, all the symptoms were there.
There are several things happening when we do this kind of intensive work. One is that there's tremendous support from the other people in the group. Secondly, we've in a sense taken them out of their environment for a while so that we have an opportunity to really build in new habits without a whole lot of interference from the daily triggers in life, and strengthen those habits so that when they go back, they're able to behave in new ways vis-a-vis their anxiety, places, and other people in their lives. And we're working at all of those levels. And indeed, that does happen.
The program uses such cognitive behavioral techniques as relaxation training and extensive travel work to help clients learn to face head-on their fear of losing control and having a panic attack. For instance, clients are instructed to hyperventilate to simulate the physiological feeling of a panic attack. When no panic attack occurs, they see they really are in control. While some people with agoraphobia are treated pharmacologically, it's a goal of this program to free its clients from the use of medication. Dr. Goldstein explains.
The role of medication is something to get off of in this program. It's our view that people don't really feel well until they have the sense that they are in control without crutches. And medication is just that. It's a symptom dampener, but it doesn't, quotes, cure anything. I would say 60-70% of people who come in here are on medications and have been tried on a number of medications. Many of them are on a number of medications all at once. So they may be taking tranquilizer and an antidepressant and maybe a beta blocker, that's something to slow the heart and so on. On the other hand, I think medication has its place. There are people who are so extraordinarily distressed or depressed that they simply can't function. And that's the role of medication, to get them through that temporary dysfunctional period.
Clients are also taught how diet contributes to the disorder. In particular, caffeine, which causes reactions in the body that may feel like the symptoms of anxiety.
So they start to get confused about these symptoms they're having. And they feel tired all the time. And they have many shifts in their energy level during the day. So it's really important for people who have these problems to eat well.
Caffeine acts in the brain as a stimulant that produces transitory anxiety-like sensations in these already aroused individuals. But the role of the brain in the anxiety disorders is still not well understood.
What anxiety disorders seem to be are a very complex array of imbalances or complications in the areas of the brain that control the various aspects of this alarm system. So we're not exactly sure of what the biology is on a one-on-one basis, but we know in general that it includes such neurotransmitters as norepinephrine, as serotonin, and there are a special number of receptors called benzodiazepine receptors that act along with what's called GABA, GABA-aminobutyric acid, which is inhibitory neurotransmitter in the brain. So as far as we know, those groups of neurotransmitters somehow interact with one another and either cause or inhibit anxiety.
The feeling of anxiety associated with agoraphobia and panic attacks can be seen in the group therapy process. Here, a couple of days into week 1, participants are still getting to know one another and expressing their fears about travel to the city.
It shook me up thinking, we're all going to go with one person.
Yeah, I thought that too. I had the same reaction.
It really shook me up.
I don't want to split up right now. I think we all need to stay. That was sort of my reaction right away. No,
please don't go.
I was really glad when I got off the expressway and back into the bus.
Mary is the daughter of an agoraphobic mother. She is married with 2 small children of her own. Mary's travel assignment, riding an escalator at the mall, is a behavioral technique that teaches her a new way to react to a situation that she fears. Here, Dr. Welsh works with Mary to get at the anxiety she feels, her deep distrust that she's not competent to handle the world on her own.
But could you tell us about the feelings you had going up and down it, and how
it was good.
You made it good?
It was good. It wasn't frightening to me or anything.
How did that progress from the first time you went out to labor? What did you do to make it okay?
Just my breathing, and I was trying to concentrate on the things that were going on around me. Watching the other people going up and down on them.
Can you feel that sense?
And watching your face.
And what's that? What happened then?
It was just nice knowing that you were down there. I don't trust people at all. I don't. Even when Jonathan left and you told him that you would meet him. I mean, I didn't feel for Jonathan because I don't trust people, you know. I'd be afraid to come back and he just wouldn't be there. I mean, I know that he would be there, but I'd be afraid that I wouldn't see it, you know. It's just, I don't trust people. I have a very hard time trusting. Even with my husband, we'd gone to the Sears store, and I was going in the ladies' room. I told him to stay right there at the cash register. I mean, it's no big deal. He only went in the next aisle, and I wasn't nervous, but it made me so mad. I mean, I was yelling, I'm like, why didn't you stay there? I told you to stay there. You know what I mean? And I won't even ask him anymore. I told him, I don't trust him anymore. I'm not going to ask him.
The first time I experienced it, I was in my late teens, and it was a fleeting moment. It came and it left, but I knew what I felt I didn't like. And then it disappeared for several months, and all of a sudden it came back. When it came back, it was constant. It wasn't something that would be just coming and going.
Unlike panic attacks, which are discrete episodes, Generalized anxiety disorder, also known as GAD, is chronic, diffuse, excessive worry, what used to be called free-floating anxiety.
I knew that I was not me. I knew that I was not normal, that that was not the way I'm supposed to be feeling. I knew that. And I knew that something had to be done, because I would even have dreams of men with white sheets on knocking at my door, and I'd open the door, and when I'd see them, I would push the door and try to keep them out. You know, I was afraid. You know, they were saying, "We're coming to get you." I had all kind of, nightmares and sleepless nights.
When I would wake up in the morning with a fast heartbeat and all the other feelings that were associated with the symptoms, it escalated to the point that I felt so crazy anyway that just with these symptoms, it didn't make sense. So then I had to create something that I would fear almost to add to this problem. I don't know if I'm making sense to you or not, but it was like these symptoms were so ridiculous. So then I all of a sudden focused on finding something that would scare me. So I focused on knives. Knives became a nightmare to me. I would think about knives. I would worry that I would hurt somebody with knives. I would worry that I would lose control and kill someone. And it would always be somebody that I loved.
What really nails down the definition of generalized anxiety disorder is the worry, excessive worry. The panic disorder people worry about having a panic attack. Generalized anxiety disorder, in order to meet criteria for it, they have to worry about other things than their anxiety. And in Donna's case, she worries about family, finances, and she has other worries and concerns too. But that's what really captures the disorder, is that they have to have two major themes of worry outside of worrying about their anxiety.
And then also there are financial difficulties. Right now it seems like everything's coming at one time.
Okay. And are you worrying as much about the finances as you are the family?
Probably about equal. Okay. It's hard to really say for sure at this moment. Okay. If you'd asked me that probably 10 minutes from now, I'd say, oh, the financial is terrible. But 20 minutes from now, I'd say, well, it's the family. I'm having trouble meeting their expectations.
Often the person with chronic anxiety has difficulty falling asleep and suffers from lots of aches and pains. Many drink excessively, and the risk of dependence on tranquilizers and sleeping pills is very high. About 4% of Americans suffer from generalized anxiety disorder, with women outnumbering men 2 to 1. Laverne is an administrative assistant for the United States Army in Washington. Dr. Lewis Hall has been treating her generalized anxiety disorder for the past 4 years.
Her symptoms originally before she came to me, included such things as the muscle tension, the chronic worry and preoccupation with difficult issues. She would have episodes that were worse than her baseline, where she would have some increase in heart rate, palpitations, some shortness of breath, and more than anything else was this feeling that doom was right around the corner, that piece that she couldn't quite get rid of, that something was going to happen, she wasn't quite sure what.
After living with chronic anxiety for many years, Laverne finally realized she needed to get help.
One day I was at work, and my girlfriend and I went downstairs to the cafeteria to get lunch. And as we were walking, I got very dizzy. It felt like I was just going to pass out. And I got real nervous and frightened. I told her I didn't want to go in there. I was just afraid that there were too many people in there. And I said, just wait right here, and I'll be all right for a minute. And after it passed for about 2 minutes, but it seems like it's 20 minutes or longer that you're going through this. And anyway, we went and got our lunch. But when I came back upstairs, she went back to her office, and I put my lunch on my desk. And as I put my lunch on my desk and I got ready to eat, I just burst out crying. And I threw my plate down, and I called her up, and I said, come take me to the hospital right now. I just can't take it anymore. And
Many patients with chronic anxiety do go to the hospital or to their medical doctor. But most often it's not a psychiatrist or psychologist they end up seeing.
Usually it's the primary care physician or the emergency room physician that'll see anxiety disorders, and especially generalized anxiety disorders. These are people who will come in because most of the symptoms of this illness are symptoms of the body. They'll come in with dizziness. We'll work them up for dizziness. They'll come in with palpitations. We work them up for that. So the person that they see first and foremost is their general practitioner or their family practitioner or the person in the emergency room.
St. Paul, Minnesota general practitioner Teresa Quinn sees many patients with generalized anxiety disorder who come in complaining of physical symptoms.
I saw a person who was very focused on neck pain. That was her primary complaint, was neck pain, and she did have some reasons for having the neck pain. But every time I saw her, the time would go by very quickly. She'd have a lot of things to talk about and, would speak in a pressured manner and would talk about other symptoms eventually, too, that were bothering her. And eventually it became clear to me that she had an anxiety disorder, and it turned out to be GAD.
It was very disappointing because for 28 years I have run from one doctor to another, and it also hurt me when I had physical ailments. There were times that I would go to a doctor with physical problems, and they'd look at me and they'd say, "Donna, you sure it isn't just in your head?"
I think the most important thing for the physician is to be aware that anxiety disorders are very common and not to miss those disorders. I think in the past we were almost trained that if we ruled out a physical disease, our job was done. And I think it's very important that we be aware of what the symptoms are of anxiety disorders so that we can either treat that patient or refer them, and also so we can educate the patient.
Even though people with generalized anxiety disorder and panic disorder feel anxious about different things and react in different ways, experts believe that many of the same factors are operating in these and other anxiety disorders. The question now is, what causes them? Is it, for instance, something that happens in childhood?
You go back and search through the history of from the time that he was a child and ask yourself if at some point in time you did something that might have caused this. This is not something you do in a day, it's something you do over a period of time. And you find yourself doing that if something you did might have caused this, or what could have caused it, really.
There's no way to measure exactly how much influence parents' actions have on this disorder, but in the case of agoraphobia and panic, most psychologists believe the role of childhood experience is significant.
I think childhood experiences are extraordinarily important. We see people who tell us over and over and over again that from very early in life, the kinds of experiences they've had have shaped them. And I'm talking about the kind of environment one needs to feel safe in or not. For those who are going to be agoraphobic, it's not.
I was taught a scary view of the world. The world was not a safe place. It was my upbringing. My mother was overprotective in that respect, and I learned to doubt whether I could handle things. It was just part of my childhood training. And to make things worse, my father tended to be critical of me, and that piled on top of it, keeping my self-esteem low and my confidence ability to break out of that cycle reduced that ability.
Dr. Lewis Hall cautions that the jury is still out on the issue of childhood influence.
We're taking adult patients who have anxiety disorders and looking back at their childhood and saying, well, gee, what's there that might account for this? The scientific danger with doing that is that we have a select population. We have a population that we know has anxiety disorders. What if we walk down the street to people who didn't have anxiety disorders and asked them whether or not they had similar or the same childhood experiences? We're just not sure scientifically whether or not the answer that we got would be that there were children who had the same experiences in childhood that did not develop anxiety disorders.
In the end, most experts feel that any single factor, like childhood experience, won't explain anxiety disorders.
So my model, and the model of most people involved in abnormal psychology today, has to do with the multiplicity of factors. It has to do with constitutional vulnerability, which is to say the kind of biological, physiological, constitutional elements that the person is born with. The most important of these, I would say, for anxiety disorders, is that people are born with different tolerance levels for anxiety. Some babies tolerate anxiety very, very well. Some babies do not. And that it seems very clear that these kinds of differences are constitutional. That is one factor. But that alone cannot cause an adult anxiety disorder. That in combination with perhaps issues that have to do with childhood history, early and later childhood history, issues that have to do with personality development, what some researchers refer to as adaptive style, the way that each one of us adapts to anxiety, and also issues that have to do with current life stress.
Dr. Schulman illustrates this multiplicity of factors with case histories of 3 different anxiety-based disorders. When Dr. Schulman took Paula on as a patient, she was about to marry a man out of her faith and was converting to his religion. Her parents were very closed about such issues.
Paula guessed that this would not sit well with them. It didn't sit well with them. So that would be what we call life stress, the stressor that was going on at the present time that figures in to the ultimate development of the panic disorder. At age 9, she remembers that there were many arguments at the family dinner. Most of them centered around her brother, who was 3 years younger than she, and was constantly getting into trouble in school. He was seen as the bad son. She was always the good girl. And she remembers being so upset about what was going on at the dinner table that she went upstairs to the bathroom and put a towel in her mouth and screamed. And she remembers doing this because she knew that she couldn't scream out loud, that she wasn't allowed to scream, but she needed to scream. This later became very important as a metaphor for what the panic disorder, the function of the panic disorder, how it was serving to keep her from being able to scream at her parents, at the people in her life that she needed to scream at, and her need to be a good girl.
Phil is a 57-year-old man with obsessive-compulsive disorder. Before going to work each day, Phil had to check and recheck the gas 28 times to make sure it was really off. He knew how irrational this was, but it made him terribly anxious not to do this checking. Phil also came into Dr. Schulman with a current life stressor, complaints of worsening marital problems.
The most traumatic experience in his life was when he was about 5 years old. His father and he were constantly getting into difficulties, even at that young age. His father was constantly critical. He experienced his father as constantly critical. He was often arguing and argumentative with the father, not doing what the father wanted him to do. There was a particularly angry period in his father's life and in the son's life around this age of 5, and his father died in a fire in the factory that he worked in.
As an adult, Phil was still trying to deal with his angry childhood feelings. Afraid that his childhood anger had actually killed his father, he was also afraid that expressing anger at his wife might kill her, too. Professor Schulman believes that Phil's gas checking was a solution to an unconscious conflict. On the one hand, it expressed his aggressive feelings, and on the other hand, it stifled them. Maria is a 27-year-old woman with hypochondriasis, intense anxiety that she is ill, even that she is dying. Every physical symptom sends her running to her physician in fear. One night she has a terrible stomachache.
What I learned was that she was asleep, and at 2 in the morning her husband came home, and in the middle of the night they decided that they would order pizza. And she ate the pizza at 2 in the morning and went back to sleep at 4 in the morning and woke up with a horrible stomachache in and out.
Typical of people with hypochondriasis, Maria believed it was stomach cancer, not the pizza, that caused her pain. In examining the causal factors in Maria's anxiety disorder, Dr. Schulman looked both at her present stressor, her recent marriage, and at her childhood.
She was raised in a very traditional Italian home, was the favored and the first child. And her father, who was seen as a very powerful figure in the family, the mother was seen as very passive and very weak. The father, who was seen as an extremely powerful figure, was someone who pampered her and catered her. This all changed at adolescence, when the father became very withdrawn and very critical of his daughter, particularly of her developing sexuality. And what Maria did was a massive rebellion. She became very sexually active. She became involved as a rock groupie during the late 60s, doing extremely frightening activities, sneaking out of the house constantly, really opposing the father's iron hand.
When Maria decided to get married, her rebellion turned inward. She became hypochondriacal, preoccupied with her health, and fears of dying. Dr. Schulman suggests that Maria's dramatic change related to her upcoming marriage.
That what Maria's disorder mostly had to do with was an attempt to disable herself to keep her connected with a powerful man, just like the father was before adolescence and after, while at the same time expressing her anger indirectly by withdrawing, by being vulnerable, by being too fragile to be the partner that he was expecting in the marriage.
It's not always clear why a particular patient develops a particular symptom pattern. Professor Schulman sums up his point of view that there are 4 contributing factors: constitutional vulnerability, childhood history, personality development, and life stress.
In the first case, in Paula's case, it was the upcoming marriage and conversion and the potential disagreement with the parents. In Maria's case, again, it was marriage, in a marriage that she had significant concerns about. In the third case, in Phil's case, it was conflict, a particularly angry conflict. So in each case, there was a current life stress that also has to be figured in. And I think it would be too parochial to think in terms of any one of these factors as being the reason for an anxiety disorder to occur. One has to consider the complex interplay of all of those forces.
For Laverne, it was a series of life events, beginning with the death of her mother, that contributed to the onset of her chronic anxiety.
I was close to my mother, and to me that was, a lot of people may think it sounds funny, but that was my God on earth. You know, losing her, I didn't really have anybody else that really mattered, because she always talked to me about everything, and you know, I was angry. I was angry at God. I couldn't understand why He didn't take my father or somebody that I didn't love or something that wouldn't hurt me. And I cried a lot. I cried for about 2 years every day, and that's when I first started getting anxiety and thinking that I was going crazy.
There are basically 3 kinds of treatments for anxiety disorders. 1, medication. The anti-anxiety drugs most commonly prescribed are the benzodiazepines, with brand names like Valium, Librium, and Xanax. These act to suppress the anxiety symptoms, making the person feel calmer. 2, psychodynamically based psychotherapy, using insight to uncover unconscious conflicts. And 3, cognitive behavioral psychotherapies, which use relearning techniques, changing behavior and automatic thought processes. In this scene, Dr. Donnell uses cognitive psychotherapy to challenge Donna's automatic thought that if she doesn't immediately pay every bill in full, the consequences will be dire.
You've been worrying about finances. Are you worried about something specific? Anything in particular?
I have lots of insurances due right now. Okay. Lots of insurances. Some things that I try to help my daughter with, even though she's, college age. Okay. Because I'm not, I'm in a limited financial situation. It makes it rough for me.
Okay.
And I'm a worrier, and because of that, I know I'm going to have to pay him regardless.
Okay.
And I know that worrying isn't going to help.
Okay.
but it doesn't seem to stop me from worrying about it.
I mean, we've talked about this before, that worrying doesn't resolve the problem.
Right.
If you have financial problems, worrying does not resolve the problem. Okay, so what we need to do is find alternative ways to deal with your financial problems.
Right.
And those things that you can't control, we're going to have to get you to let go of again, and find ways to have you let go of them. Okay. If you're on a limited income, what keeps you from paying part of the bill and saying you'll see the rest in September or October?
Right. I'm just that type of a person that I don't like to receive bills.
Okay.
I don't know why. I think it's probably from the past because of never having money as a child.
Does it trigger your worry then when you receive the bills and you can't pay
It triggers
for it?
my worry. I'm immediately thinking, hey, I'm not going to be able to pay this. Even if I probably would have the money, I would think, oh my God, I'm going to be walking out in the streets.
So what will allow you to let go of it if the bill's unpaid? Hey, are you in risk of losing your home?
No.
Okay.
What will allow me to stop worrying about it?
Is it the end of the world if the bill only gets partially paid?
No.
Okay.
I just have to learn how to let go.
Yeah.
Now we turn to behavioral psychotherapy. As we saw earlier in our program, the Agoraphobia Clinic uses behavioral psychotherapy to help its clients learn new behaviors for anxiety-producing situations. Here it is used to help Roger and Mary tackle their fear of heights.
Let your eyes focus and just let them wander around. Focus on what you see. Pay attention so that you know what they're doing down there.
I'm sensitive to mostly heights, and that tends to come across in major city traveling where there's likely to be a tall building that I might have to go into. Even open shopping malls with 2 or 3 stories that are open down, that was a real problem for me. Is a problem for me.
Oh, there he is. He's right there. Yeah, heights, open spaces. He's really having a very hard time. See him holding on to the railing? He'll come down. I think he's all right, Alan. He's going to come down.
Finally, we turn to classical psychodynamically based psychotherapy. Its goal is to get at experiences and conflicts instilled in childhood and out of the patient's current awareness.
And in the psychoanalytic forms of treatment, the basic assumption is that what needs to be done is a person needs to make, if a person has a neurotic disorder, if a person has an anxiety disorder, that it's because they have unconscious conflicts, primarily rooted in childhood experience, but that they have these unconscious conflicts. And if one could make the unconscious conscious, if one could bring to consciousness these unconscious conflicts, then the neurotic disorder would dissolve. In this way, psychodynamic treatment is really based on insight. The fact that what the analyst is trying to help the patient do is gain insight into his condition, gain insight into his unconscious. When you're a child, you put something in the unconscious. It is buried. And as long as it's buried, it stays intact. It stays the same way it went in when you were a child. It's only when we unbury something, which one can do through psychoanalysis, that one can, then that thing, that memory, that fantasy, that idea can no longer be intact.
In the real world, it is almost always a combination of therapies that is appropriate. In this scene, a combination of cognitive behavioral and psychodynamic psychotherapy is used with Mary to work on her feelings of anxiety about being asked to drive alone.
So what would you like to say to us about this, about putting you in a situation, pushing you, asking you to do it one more time?
Are these people for real? Are they going to make me go out and go in a car like this?
Say that to me and say that to him.
Are you going to make me go out in a car by myself and just... Why is... I mean, when I'm not ready, when I feel like I'm not ready.
Can you say what it feels? It really makes me feel when I think you're going to push me into something I'm not ready.
Yeah.
Make a nice statement instead of a question.
You're going to push me into something
That's a question.
that I feel like I'm not ready for.
Uh-huh. And? How's it make you feel?
Part of me good, part of me bad, because I feel like I do need a push. But it's just, I'm afraid to get pushed. I'm afraid to get pushed, but I need a push.
And how do you feel about the person who pushes?
Pardon me?
How do you feel about the person who pushes?
angry and...
It makes me angry when you push it.
Mm-hmm. But I want it.
Yeah, I know. What we're asking you to do is to take a chance, make a direct statement about what you're feeling, and see what happens. Maybe things have changed. Maybe it's not so dangerous.
I think out of all the anxiety disorders, generalized anxiety is probably one of the more difficult to treat. And especially with the chronicity of anxiety. Donna talked about a 28-year history. She's experienced anxiety and worries for over 50% of her life.
I told you that the tingling of the feet and the fingers and everything, and I thought, hey, this is hyperventilation, and these are why the symptoms are getting worse.
And we need to get your arousal back down under control, okay? I want you doing your breathing, all right? And I want you slowing all your bodily movements back down again. All right, so I don't want you pacing. It's nice to go out for a relaxing walk, but I want you pacing, and I want you doing your diaphragmatic breathing. All right, I think that if we can get your arousal back under control, your worries are going to seem less excessive. All right, and we'll be able to, we'll be able to stop them, but we can't do it until the arousal's back down. So get your breathing back under control. What I want you to do over the next week is monitor the times that you feel someone's placing a demand on you, and you don't really want to do what it is they're asking you to do. And I want you to write that down for me, okay? And bring that in, and we'll use that as material in this session.
For the past 4 years, Dr. Lewis Hall has been treating Laverne's chronic anxiety with a variety of techniques. While cognitive behavioral psychotherapy has brought positive results, it's through medication that Laverne has found the most relief.
She's on Xanax and has done extremely well. The question you always have to ask yourself about someone who is on one of these medications is now enough? Have they been on it long enough? And usually what we do is to follow to ensure that they stay on an adequate dosage but are not overdosing themselves. And most people do stay on stable doses. If you start on X amount, you stay on X amount for the many years that you're on it. But periodically you have to review the case and know whether or not it's still warranted that a person would have to stay on medication.
I'm not frightened of anything. I can ride an elevator, I can ride the subway, I don't think of any of those things anymore. And it just calms, keeps me calm. I don't get anxious or anything. But if I do, then I'll take the medication, or I'll talk to myself and tell myself why, that this is something that happens to me, and to let it pass, because at one time I was trying to stop the feeling, and then it gets worse when you try to stop it. So it's best to let the feeling come on and go away. I wouldn't do without it. Right now I would be afraid to not take it. I would be very afraid to not take it.
We returned to the agoraphobia clinic in week 2 of their program to see how the participants were progressing with their treatment. They had made great strides in only 2 weeks. Mary was now driving alone. Roger had crossed numerous bridges. And Patrick drove alone to Atlantic City. Although they had not become panic attack free, there clearly was improvement.
Well, I got my license and I drove twice. And the second time I had a pretty bad panic attack. So then I avoided it for a few years, and then about 2 years ago, I drove for a couple weeks. And then I had panic attacks again, so then I haven't driven until now.
Yesterday, on one of her driving assignments, Mary had and survived a panic attack.
Scary. I didn't think I could keep driving, but I did.
Linda was with you then?
No, I was alone.
So where were you when you saw you were having the panic attack?
On City Line.
And then what did you say to yourself to keep yourself going?
Got mad at myself. Cursed myself. But I just get mad at myself, and I just feel bad because I think I shouldn't be like this, and I shouldn't have to be afraid. No one else is afraid. I'm just like everyone else. And I'd get mad at myself, and that would give me more courage, and I'd be able to keep going on.
There are some bridges, a couple, one in particular, high bridges near the airport that I have not crossed by myself, and I'm not sure if I've crossed it with anybody in the car, driving for 6 or 7 years probably. And yesterday I had probably a total of 14 or 15 passes across those two bridges. That felt great to be able to do that and not have the panic attacks.
Patrick describes the symptoms he worked through on the way to Atlantic City.
Going down the road, going to Atlantic City, I noticed my breathing was getting shallow. I was mildly hyperventilating. And I sort of talked myself out of it. I mean, practiced my breathing techniques and everything, and it went away a whole lot quicker than it usually would. In that situation before, I would have pulled over and been real scared. But from coming here and learning what I learned and knowing what I know from here, I was able to handle it and keep going.
As he surveys a nearby college campus, Patrick fantasizes about his future life as a college student.
I think it would be a little bit scary, but I would adjust to it, I think, pretty easily.
So you'd say, this is hard.
Yeah, and then after a while I would say, it's getting easier and easier and easier. Probably worry more about my classes than anything else, working classes, getting the homework done there than being away from home. I think it would.
So you could
It's like two different people. Like I was a kid last week and an adult this week. I'm a lot more assertive, go places on my own a lot easier, just completely different. Now, there's real good hope that I will get to go to college.
While there are similarities among most psychotherapies, the difference between using psychological treatments and medication is significant. Just when to use these two forms of treatment and in what combination remains a difficult and often sensitive issue.
Some of the anti-anxiety medications are addictive. Very important to keep in mind. Some of the anxiety medications require very difficult withdrawals. As a matter of fact, some people have noticed that withdrawal from Valium is as bad as withdrawal from heroin in terms of the experience of the person, that it's not to be taken casually.
Withdrawal is not the only danger with medication.
The benzodiazepines we're not sure about in pregnancy. The rule of thumb for medication is don't use it if you don't have to in pregnant women or in nursing women. Or in women of childbearing age, because they don't always know right away when they're pregnant, and that first period, those first weeks that they don't know, is really when the baby is being shaped. So you want to be as careful as possible. Some of the side effects, not of the benzodiazepine group as much, but of some of the other groups, are sedation, cognitive impairment, and they're not quite sure, although there's no real evidence on the table, that it would cause any deformities in babies. But that's something that we don't want to find out, at least not the hard way.
This is the reason why I so strongly believe in psychological treatment. There's also been great advances in medication treatment of anxiety and of panic. But if you don't keep taking those medications, you are virtually assured of relapsing.
In addition to that, it's very clear that some of the medications, the ones called minor tranquilizers, the benzodiazepines in particular, Xanax, the most commonly used these days, actually interfere with one of the processes necessary for getting over, that is, permanent change of the fear. And there is data to support that. We certainly see it clinically all the time.
Once you've made a diagnosis and the person is prepared for treatment, you discuss the options. When you think that it's legitimate is the same as you would think that medication was legitimate in non-anxiety related illnesses. So if you find that the intensity of the person's behaviors, feelings, and thoughts are so great that they interfere with their day-to-day life and they can't wait, so that if they're suicidal or feel that they might hurt themselves or somebody else, then you start medication right away if possible. The second possibility is that once you've tried psychological or non-pharmacologic treatments and they have not worked, or the benefit is good but they're not quite 100%, it's possible to go ahead then and to use medications. The last possibility is that you plan ahead of time to use medication in order to right the biologic wrongs in a person and prepare them to receive these psychological treatments that work so well.
Well, it's nice to wake up and be alive. I'm glad to be alive. It's like I was freed from a prison. I feel that I'm normal, and that's the first time I've felt that I'm normal, and that I wasn't crazy, and that I wasn't insane in 28 years, and it's a good feeling. It's like being freed.
I've been given good coping skills, and understand the dynamics of what's going on underneath the surface, and we've learned a lot of lower level information about our childhood, and in particular I have gotten in touch with some things in my past that explain this. It's not a mystery anymore. I think I understand to a large degree what's happening, and that's 3/4 of the battle is knowing what's happening, being able to understand it.
I didn't know as much about it that I do now. And now I know I'm not going crazy. I know I'm not going to die. I'm not going to faint. And I know I can control it.
I told somebody that I was trying to catch up on a lifetime in 2 weeks. It sort of seems that way, and it's just real weird. I mean, it's like a transaction from child to adult. It seems like before it seemed like it was I was depending on others, and then now I'm depending on myself. I feel like I'm not alone. I'm with me. I don't know how to explain it.
The future it looks good. It's going to be good. Can't get any worse. I know that, because those days were the darkest days that I've ever had. So I can see the green trees now, and I can hear the birds sing, and I'm not just going through the motions anymore. So and then I'll know how to handle things from now on. So I know the future is real good. No problems there.
Funding for this program was provided by the Annenberg CPB Project.
To learn more about the Annenberg CPB Channel series and workshops for teachers, how to take them for credit, how to buy them on video cassette, call 1-800-LEARNER and visit us at www.learner.org/channel. The Annenberg CPB Channel.